the sheath, which is like encompasses everything, which can also get inflamed. And the picture is kind of just like how the units of the tendon kind of fit in the tendon. It's just a bunch of units that kind of go around each other, and then they get clustered, and then get another unit, and it's like that type of thing. Okay, so common injury processes. They can be chronically exposed to volumes or magnitudes of loading. Patients who do a lot of lifting. I had a patient once who had a chronic tendinosis because he shoveled 5 pounds of plastic every night for 8 hours to make surgical equipment, and that was his job. So he had lots of problems with that. So it's chronically exposed to loading or injury that's beyond what the tendon can handle and the muscle is conditioned to handle. Sometimes they have cycles of it, where they have inflammation and swelling, and then they kind of calm down a little bit, and then of course they re-aggravate it because they go back to doing whatever they were doing, and then it kind of goes in this giant cycle. Tensile overload may be the dominant mechanism for many tendinopathies. So it's like some of it, just like we were just talking about, is that lost my train of thought. Yeah, so some tendons, it could be an individual unit is not pulling enough compared to the rest of the tendon, so maybe a portion of the tendon compared to the other portion of the tendon. So that's where you have differential tensile overloads, and that's sometimes why in a muscle belly and part of a tendon, it's like the left side of it hurts, but the right side doesn't hurt, because they compensated not that way. And then, like I already covered, is it can go on for cycles, where we have some people here who come in with like acute tendinopathy and they rehab and they do really, really well. And they go back to doing whatever they were doing and weren't stretching or conditioning or anything like that, and then they end up back in here with the same exact problem. Or they can have chronic tendinosis, where it's just chronic problem, and then we have to work on kind of reconditioning and trying to get the degenerative changes to stop and kind of re-heal back into the way we want them to do. A big thing is with tendinopathy, especially with like Achilles tendinopathy or something like that, is the movement patterns. It may be slight out of the correct movement patterns. They may be stepping slightly internally rotated, slightly externally rotated, which then causes extra stress on it and can cause a lot of the pain and problems over just overworking it too much. So maybe the movement pattern specifically compared to like just doing too much at one time. So there are a couple different extrinsic and intrinsic factors that place tendons at risk. Extrinsic factors is like lifting too much at one time, trying to throw, like I had a guy who has shoulder rotator cuff tendonitis because he picked up a heavy suitcase and threw it into his car. Or something like that. Compared to intrinsic factors, which is like biomechanic, if they have like malalignments, like flat feet, or like knock knees or knee bowing, that can cause a lot of tendon stress on like the patellar tendon. And then of course, if age sometimes, or if they're overweight, puts extra, because then they're kind of waddling or however they usually walk, just because they're not walking like they should walk, they put extra stress on it, and then their body's carrying extra weight too, so the muscles and tendons have to work extra hard to hold them upright. There is also, which I started to ask all my patients who come in with tendinopathy, certain medications can actually cause tendinopathy. So like your fluoroquinolones, your corticosteroids, if they've had prolonged use and then they start to develop it, then we're like, well, maybe a medication thing. Not necessarily. If they're like, oh, I don't know what happened, it just kind of started. But I'm like, well, what kind of medication are you taking? And they're like, oh, I've been taking this steroid, or I'm taking prednisone. I'm like, how long have you been taking prednisone? Oh, 4 months. You may have some tendinopathy effects because it decreases the tensile load. So that's a good thing to always ask. Be like, check the medication list and see if they're actually taking prolonged things, because, you know, people aren't medications free. God knows how long and how
What
much.
is the fluorocarbon?
It is
Like, what would it be used to treat?
it's an anti-inflammatory. I believe. Yeah, I think so. Yeah.
Antibiotics.
Antibiotics are too. Yeah. And
Statins
it's-
are blood thinners.
Yeah, statins are blood thinners.
Isn't it like cholesterol?
Statins, yeah, statins are cholesterol medication.
Is there still? Cause I like looked that up the other day. I don't know why.
Ciprofloxacin, I think does it too.
I think so, but like are statins still like considered like to be reasons why people would get like a tendonitis or a tendinosis? I was reading something that was like, you know, like older medications like probably, and obviously if you do like more than like 5 or 10 years,
Yeah.
anything is gonna kind of cause it. But they were saying like the newer statins like shouldn't.
I know some of the newer market ones aren't as bad, but you know people on their statins aren't going to change. So unless they start to have a problem, they're not going to change.
So I started to like tell somebody that, and then I was like, you know, thinking about like, oh, I want to go back to their doctor and say like, Kelly says that statins are bad for you. Like, I'm gonna get off my statins. I like stopped talking. I was like, I'm just gonna not tell you that bit of information until I find out more, because I don't want that to come back and bite me.
Yeah. So the new research has also shown that nervous system sensitivity plays a big thing, because a lot of medical imaging like MRIs and things like that aren't conclusive with jack crap for tendinopathy. Some patients, they've did research where some patients have like severe degeneration, tendinosis, degenerative changes to their tendons, and are totally asymptomatic, have no problems whatsoever. And then some people are super symptomatic and have like very minimal degenerative changes or none at all. So imaging is not conclusive at all. It's just like not even worth paying attention to. So like I have a patient who is like 9 out of 10 pain, super sensitive, but they're like, oh, I had an MRI, it didn't show anything. So a lot of nerve starts to come in. It's like the neuromuscular junction gets sensitive and everything gets tight, and then they don't want to use it, and it gets worse. So I've started to incorporate a lot of like nerve glide type exercises into my tendinopathies, especially into my hands and elbows. The Achilles aren't so bad. It's mainly the upper body has some more nerve sensitivity. But that's a new way to look at it now too, compared to just be like, oh, it's just a muscle tendon type thing. It's can incorporate, especially if they're super sensitive and everything like that. But yeah, that's a crash course on new tendinopathy stuff.
Do you use like the word? I always just kind of like if they come in with like pain in right shoulder, like no definitive diagnosis one way or the other. Like I usually just write like rotator cuff pathology.
Yeah, usually
or like
rotator cuff.
Like I write tendinopathy. So I'm like, it's just
something like that.
Yeah. Or do you try to write like tendinosis or tendinitis? I feel like if they come in, it's because something must be inflamed. But I mean, it could be like an osis where it's just been aggravated.
So long. Yeah, it's just been so aggravated. No, usually when they come in like right shoulder pain, I at least narrow it down to like rotator cuff. I'm like rotator cuff syndrome or something like that, or tendinopathy or something like that. I don't say tendinosis or tendinitis really.
Yeah, okay.
But at least narrow it down from right shoulder pain to like rotator cuff or labrum or biceps or something like that.
Yeah, that's what I do too.
Any other questions?
Want to show them maybe some of the nerve glides that you're doing?
Sure. So with my upper body nerve glides, there are a couple different ways you can do them.
I know.
But the easiest one is if they're like chilling in a chair or whatever. So with your median nerve glides, I usually start with their arms straight out to the side. Throwing stuff, Sean.
Yeah.
And then I pull it back just a little bit, and they're gonna flex their hand. And you usually feel it like right here, and it pulls all the way up the arm. And if they're like, oh, I don't really feel it, you can turn your head away, and you get really a lot more. And I usually hold it for like 5-10 seconds. Any more than that, it's like really uncomfortable. So 5-10 seconds, I usually about 10 reps.
I don't think they're supposed to hold it that long, right? Either.
No more than 10 seconds.
Okay.
Yeah, no more than 10 seconds.
I always tell my
Thumb
patients to like
shaking
turn it on and like turn it off.
Yeah.
Like, turn on your pain, turn off your pain.
And I always warn them, I was like, these do not feel comfortable. They're gonna burn. They're gonna numbness, tingling. I'm like, that's very typical. Afterwards, it's supposed to feel better. That's what I always tell them. Because they're like, oh, it hurts, I'm not gonna do it. I'm like, it's supposed to hurt while you're doing it. It's supposed to hurt less after you're done doing it. So this is a median. A radial is you're just gonna flip your hand over. Do the same thing. She feels it.
Do it.
Yeah. So
I'm also
it's
very
me.
strict on how, like, I'm like, do it 10 times in the morning and 10 times at night, and do not overdo that exercise.
Yeah, I'm like, do not.
'Cause it will
I was
hurt.
like, do not do
It'll
more than
just
twice a
make
day.
Yeah, it'll make it
Some people
so
do it
much
more.
worse.
Yeah.
No, don't. This is the one exercise where, like, more is 100% not better.
Yeah.
More is
You're
so
like,
much
the more I
worse.
do it, the better. I'm like, no, not with this. Absolutely
More
not.
is so much worse.
And then so with your ulnar, you can do it a couple different ways. If they're really flexible, I can make an A-OK sign and do your Batman goggles.
I love it.
Or if, because a lot of people are like, I can't get there,
Yeah,
so I just
so-
have them raise up and kind of do like this. So it's almost like a beach pose.
Batman dog.
Oh.
Yeah.
Whatever I tell you.
And you'll feel it in these 3 fingers.
And you wanna hold
You
that
work
one
on
too?
your first
Yeah, 5
box,
cents.
and you work on
Yeah.
some.
5-10 seconds, 10 reps or so.
My right elbow is a mess right now. I need to do all these.
Yeah.
The only
So those
time
are 3
I'm
upper body
twisting.
ones. Yeah. I find that most of the sensitivity happens in the upper body and the arms and hands and stuff. I rarely find it in the lower.
We
the
had,
Achilles
you
right
did
there.
the nerve light on, I did that the other day.
Yeah, that's it.
I
mean,
do a
just
lot of
more or
sciatic
less-
nerve glides with my radiculopathy patients.
Yeah.
That's where you go.
I usually just do like leg lifts and like flex and point there.
You look up for that.
And then I always like
Like
incorporate
the
like
one, the husband that I had this morning,
Yeah.
his sciatic nerve is so on fire, he can't even get 60 degrees of hip flexion. It's ridiculous.
oh well.
And he sits like this the whole time.
Yeah. I always try to incorporate like soft tissue stuff into it too, because like if you think about the nerve, the tendon's probably inflamed. Now maybe the nerve is trapped. So then like, what is trapping the nerve or what is trapping the tendon? Like you want to try to mess with like all that fascia, like all that tissue around it, because there's just
Because the nerve can be entrapped in the usual spots of like the carpal tunnel or like cubital tunnel, but it can also, if the muscles are really, really tight, it can squeeze on the nerve because the nerve has to glide between the muscles to get
kind of
where
like
it's going.
the piriformis muscle that we all
Yeah.
kind of work on. Like I mean, you hit that and you know exactly it's gonna shoot down your leg. You keep working on it. It kind of comes back up the thigh. All of a sudden it's like just right at the butt. Then you can kind of deal with everything else. But the same thing in the arm. Like, you know, I mean, yes, they have pain that's just shooting into here, but is it elicited when you press on this? When you press over here? When you press up here? Does it start all the way up here? Like where, you know, kind of like finding that spot like on the hose, like that's gonna cause all the pain. So just trying to loosen it up in the entire chain.